Excellent. So I'm really delighted to share about how we can move the emerging discipline of infodemic management forward to ensure better access to credible health information and better health for all. And I think we'll all remember just over a year ago, the World Health Organization Director General raised the alarm about the twin challenges of fighting an infodemic while fighting an epidemic. And as we all know, an infodemic is about much more than misinformation. It's also about an overwhelming amount of information and information gaps and confusing messaging that altogether are making it really difficult for everyone to know what to do. So we know we need to better manage our entire communication ecosystem, both online and offline, to ensure universal access to credible health information as a basic human right. And to do this, we need an evidence-based framework to manage infodemics as a key driver of epidemics. And we need to integrate infodemic management into our health security preparedness and response plans so we can more rapidly flatten the infodemic curve, which you see here, to help flatten the epidemic curve. So this means investing more in advancing our social listening capabilities to better understand the spread and impact that an infodemic is having, and to better track changes in narratives over time, because this is what's going to help us more effectively tailor our public health response. We also know that we need to strengthen ongoing evaluations of interventions so that we have strong feedback loops in place for a more adaptive response that's tracking the changing concerns of communities. And so if we go back to the previous slide, Harry, for a second, I want to flag up for a moment here that the World Health Organization Public Health Research Agenda for Managing Infodemics has called out key areas for accelerated investment in research, including for advancing social listening, also sometimes referred to as infodemiology. And I want to note here as well, you'll see at the bottom a little call out because there are special journal issues coming out this year on infodemiology as part of this initiative that I want everyone to watch out for. But now to the next slide and to the question of how how we're applying social listening right now for COVID-19. So there's a lot more ground to cover than I can for a short presentation. So I'm going to focus on one area here today with a few examples, and I'll share a little bit of history briefly first. So starting in March of last year, the EpiWin team at the World Health Organization initiated this collaboration to develop weekly digital intelligence reports to help detect community concerns and sources of confusion. And the aim is to be able to more quickly identify and fill information gaps using trusted sources to help people know how best to protect themselves and each other, especially before misinformation goes viral, potentially filling those information voids. So while offline social listening is also key, knowledge, attitudes, practices, surveys, and focus groups, they're really valuable, but they can take a long time to generate results. And by the time those come in, people's concerns or understanding might have changed. So digital social listening, we're seeing it as a very helpful proxy with some faster indicators of community concerns. That said, it's still a heavy lift for public health teams to try and manually comb through publicly shared comments across the different platforms and subscription services, especially during a health emergency. So you heard in the previous presentation about the social listening public health taxonomy that we co-developed for COVID-19 to help better focus our searches to save our teams more time. Now, these digital intelligence reports are being shared with our colleagues and partners with actionable insights to help target risk communication and community engagement efforts for accountability to affected populations. So this system that Amy and Tina already presented on is ongoing, while in parallel, we're also developing a new tool with CityBeats for automating this kind of social listening approach for insights in near real time. So Harry's going to tell you more about this platform in a moment, but first I just want to emphasize that there's no such thing as a magic dashboard that's going to solve all of our problems. So a really key component, Harry, if you can zip back to the previous slide, a really key component of our social listening program is training infodemic managers from around the world to use the tool to analyze the data and develop infodemic reports with actionable insights that can better inform decision makers for public health and social measures that are more responsive to the needs and concerns of citizens. So our social listening work, it's being translated into action at headquarters, and I'll tell you more about that in a moment here. But first, I want Harry to jump in and share more about this exciting new tool for the social listening toolbox. Over to you, Harry.
Thanks, Chris. Hi, everyone. So let's take a look at the challenges that we're looking to overcome with ears, which are the same ones which inspired us at CityBeats, which is the product under the hood of ears. What we've been seeing is that there's this wave of new technologies in natural language processing and machine learning, but all too often that new technology is applied just to branding or marketing focused efforts. And our mission is to apply it towards public health into something that's usable here. So the big challenges are actionability. How can we make features which are not just about identifying what people are talking about to sell them more products, but more about identifying information voids in the field of public health. We need to raise the bar in terms of the reliability of data quality and more robust analytics tools that are being used. We need to make sure that all of this is scalable across different public health challenges and across languages in a very easy and fast way to set up in a crisis. We need to make sure that information is flowing quickly with near real-time proxy indicators. And ultimately, it needs to be usable. So rather than many tools fragmented across lots of data sources, the vision is to bring it all together in one place in EARS. So with that vision, we're already underway. Since the beginning of this year, we're piloting in 20 countries. A couple more are on the way, and shortly we'll be covering all of the WHO regions. This is all about leveraging big data and putting it in the hands of public health professionals who can turn it into action. So we're currently preparing a paper called Developing AI Technology for Social Understanding Beyond Brand Monitoring. And this highlights the different pieces of technology that we've fine-tuned for serious social understanding. And what we'll do today is talk through some of them in the practical application of EARS. So looking at the type of questions that you would want to answer when using EARS, the first one would be, as an infodemic manager, just to know what's the conversation, what are people talking about, and where should I focus this week? So to do that, we've been building off the back of the WHO social listening taxonomies that you saw in the last presentation. And these are categories like the cause of the virus, stigma around the spread, confirmed symptoms, and there's 39 of these categories being tracked. In this case with EARS, we've set that up with the CityBeats semi-supervised algorithm for classification. And what that means is that by giving a couple of examples, 5 or 10 examples of people talking about the cause of the virus, our system uses machine learning to figure out every day, looking for local references, new terms in the conversation, local dialects or like local slang in each country about which other opinions should also count as cause of the virus. So that means for the people using this tool, you don't need to build huge comprehensive dictionaries of each category. And you don't need to worry that if the conversation cover changes, you'll miss it. So it's all about scalability and ease of use. Once you have those categories set up, you can do all sorts of interesting things, like seeing which countries are outliers in terms of the conversation and also which are the rising terms. Chris, do you want to add anything here in terms of how they're being used at WHO?
Yeah, thanks, Harry. I think it's nice building on the point that Amy made earlier about the value in trying to move beyond this obsession with volume. So if we're only focused on narratives that are getting really wide engagement, by that point, it's too late. You know, we're on the back foot in that reactive space, trying to debunk issues rather than identifying through horizon scanning, looking at velocity, you know, those changes in volume over time, what is going to be the next big issue, and trying to more proactively communicate and inoculate people against harmful narratives and fill those information voids more proactively. Over.
Okay, and then another thing we want to do is go from the general all conversation down to the most actionable parts. So for this, we've developed intent detection of what are people asking about and what are people complaining about. This part is done with a supervised algorithm. And what we found was that it wasn't as simple as just saying any phrase which says what, why, when, who, and a question mark. That actually the majority of times is not a genuine question looking for an answer. So we've trained the system on public health data to really look for those actionable questions, looking for a genuine answer. The same thing with complaints. We're not looking at insults or negative sentiment. We're looking at really complaints as a definition of where someone's expectations of reality are not fitting with their perception of how things are being done. So the most actionable types of questions and complaints. We're also looking to develop more of these intents, things like trust detection. So maybe just to skip forward, we're also looking at population segments like gender gap detection, and in the future we'll be looking at more segments like healthcare workers. You can see in the tool, in the EARS backend, you can quickly drill down into an important conversation category. You can see how that interacts with other categories. So for example, vaccinations here we're seeing in Nigeria is very linked together with faith and sources and influences. And then you can drill down all the way to see unsupervised machine learning, which are these conversation clusters. So within vaccines, you can click into safety or people talking about access, and drill all the way down to the individual documents. So this is all about helping you quickly go from seeing the big picture down to the concrete insight. And then I'll hand to Chris to talk about how those insights are turning into real action.
Thank you, Harry. So at EpiWin, we have this process of analyzing the social listening information that's coming in on a weekly basis, and we meet to assess, what are the emerging priorities for action, and then we feed that into initiatives that we're undertaking here at headquarters and in support of regional and country teams, as well as flagging up insights to partners so that they can take action as well. And this is ranging from inputs into the global press conferences that are happening, the Science in 5 videos, to the risk communication and community engagement packages that our team is developing. This includes engagement with global faith and youth networks. And we have an ongoing series of EpiWin info packs and global webinars with live Q&A that we're doing as well. And I'll touch on a few quick examples here. So seeing increasing reports of worrying prescription practices that are happening. I wanted to flag that there's actually a webinar happening today, for example, to clarify therapeutic guidance, including the latest updates. And given increasing questions and concerns that we picked up over so-called quote unquote vaccination passports, and also about vaccination for pregnant and lactating women and for children, I wanted to encourage you to also watch the recent EpiWin webinars on those topics. And the links are included. Great if you want to subscribe to the YouTube channel and also register for those live Zoom meetings, because it's a wonderful opportunity to come and ask questions in real time of the experts there. Now, thinking about moving from the global level to a few quick examples at country level here. So the high level of transmission in India right now, which is worrying, it's created a greater demand for information about home care and home care guidance. And so the risk communication and community engagement team here mobilized to quickly develop a new global package and have been supporting the regional and country team initiatives on this as well. And in Nigeria, you might have noticed on that slide that Harry showed previously, there was a big uptick in conversations around vaccines. And this was largely driven by an influential faith leader raising concerns recently. And so the EpiWin team responded by reaching out to our faith networks, and we organized a confidential listening session to understand the concerns and the rumors that were spreading. And then we provided a technical briefing with Q&A from WHO experts, so those who joined could then share credible information confidently within their networks. And one other quick point I'll raise is we noticed a spike in healthcare worker conversations about vaccines in Nigeria, and we were able to do a deeper dive using the platform into the main questions and concerns driving those narratives and that spike in conversation. And we were able to then share those ideas from the healthcare worker community with the Nigeria Center for Disease Control as an example in support of their ongoing activities. And there was great discussion about, the possibility of having lanyards or badges for the vaccination cards for healthcare workers so that they can role model that they've been vaccinated and to help attest to the safety of the vaccines and encourage others to get their shot as well. And the last one I'll raise here quickly because I want to make sure we have some good time for question and answer. A few months back, we detected a rumor about forced vaccinations in schools in the Democratic Republic of the Congo. And we alerted our UNICEF colleagues and shared these actionable insights so that they could prepare for outreach to educators, to assist in outreach to parents, to reassure them that this wasn't in fact the case and to share more information about immunization. So with this, I want to emphasize the value of translating these actionable insights into action and invite everyone to sign the petition to engage in infodemic management in your daily life and flag up the next infodemic training session we have coming in June to support people in doing this kind of social listening work. And for more information, delighted for everyone to get in touch. We're still in the R&D phase here for EARS and encourage ongoing collaboration. Over to you, Harry.
I think that was where we were going to finish for today, right? Or I don't know if we're going to talk, if we have time to talk about next steps for EARS.
Maybe we can do that in the Q&A. Should we do, Muriel, do you want to come in for questions and answers?
Yes, I would love to, and I think we are at time, so you guys made good use of the time today. So thank you both for your wonderful presentation. I think now we would transition into the Q&A sessions. And maybe I can start with you and Chris and Harry with the first question. So we had a question about if you can sort of tell us, you know, what's next on the horizon for EARS and where do you go from here?
That's a great question. So currently, I just mentioned we're in the R&D phase here. We're in the process of adding more countries and languages to the platform and would be delighted for people to use the open access dashboard and share your feedback. We also welcome collaboration. So that addresses the upscaling. I should say as well that the platform, we're currently focused on using our COVID-19 taxonomy that we've developed, but certainly this kind of approach is applicable to other health challenges. You know, this kind of ongoing monitoring could be routine, looking at myriad health challenges from, you know, Ebola outbreaks, influenza outbreaks, looking at tobacco, alcohol, other health issues as well. So we are very encouraging of collaboration in this space. This is also a part of a broader social listening program we're developing here at WHO. So this conference is a wonderful stepping stone and contributing to our ongoing development of social listening guidance. And we are also working on global training. The next one is coming up in June, and we'll pop the link here in the chat. And we're also preparing for regional trainings, including country focal points as well. And I should mention that I think Harry raised earlier that, you know, one of the challenges for the public health teams is trying to cobble together information from a bunch of disparate sources. And so we really see opportunity to make EARS a one-stop shop of sorts, bringing in different data sources for triangulation. And for those of you who attended the first day of the conference, you will have noticed the press release and the great presentation from our colleagues at UN Global Pulse talking about the development of a radio speech-to-text translation tool. And there's the ability to use narratives coming from radio programs that are captured in structured data and upload that to the platform to triangulate with messaging that's coming from digital intelligence. And there's so much value in doing that kind of work because there are marginalized communities that are going to be more reliant on radio transmissions than information coming through social media, for instance. And of course, behavioral data, you know, it's a challenge because it takes a lot longer to pull it in, but it has incredible value. And so here we get these really fast indicators of changing community concerns. We can develop theories to test and then go and do focus group discussions or key informant interviews or knowledge attitudes practices surveys or SMS surveys and test those ideas and do some deeper dives into trying to figure out what the behavioral drivers are for changes in attitudes. And because we can upload other structured data into the platform, there's the opportunity to also look at the incorporation of information coming in through chatbots. And WHO has been working on chatbots for COVID-19, so questions coming in there could be incorporated as well. Harry, do you want to talk a little bit about the analytics?
Yeah, as mentioned, one of the main focuses of EARS is making sure that we extract something actionable from that text, from those opinions. So we're going to keep moving in the direction of more intense detection beyond questions and complaints, and then also being able to apply that to topic areas beyond just COVID-19. So looking at vaccines in COVID-19 or vaccines in general. And then we're also working on some new features such as trust indicators, which could be applied to the vaccine topic. So looking at trust or lack of trust in certain vaccines. And then also looking at indicators from the text, like rumor cues, if we can also get a quick read on those as well.
Great. And I guess I should probably emphasize here too, the value in being able to disaggregate by these different intents is to help save teams time. So it's incredibly useful to be able to quickly check in if a conversation is being largely driven by questions, where there is a lack of information, and that tells us that maybe we need more guidance, or maybe guidance is being caught in a particular echo chamber and we need to try and expand the reach to other networks and communities there, or if there are complaints that are really focused on frustration with a particular element of a health program, of public health or social measures, and maybe there's a need for more reassurance or an adaptation of the approach for some of those logistics. And then flying up a final point here really quickly, because I want to hear more questions coming in for the other experts, is the need to complement this kind of social listening work with also analysis of the communication network itself to try and identify those key influencers. Yes, that's a part of it, but also pick up where there are isolated communities where there's a lot of polarization, so we can figure out how to try and improve outreach so that everyone has access to credible health information, and to also be able to detect the difference between authentic narratives that are driving conversation from citizens versus disinformation campaigns. Over.